I want to start this video by doing a shout out to one of my followers. Thank you for the thoughtful comment and the trust. You said you're menopausal, roughing it out. You've had years of what people call estrogen dominance. You have a family history of breast cancer, and you're not sure you feel comfortable with exogenous hormones. You also said you've been doing keto for about 5 weeks and you're already feeling improvement. That's a big deal. So today we're doing a calm, evidence-based deep dive into HRT, hormone replacement therapy, and menopausal hormone therapy. We'll cover what it is, why it became controversial, what the best data says now, who should consider it, who should avoid it, and what to do if you're stuck in the I want relief but I don't want regret zone. Because menopause is not a character flaw. It's biology with a flair of drama. And let's clear up the biggest myth right now. Hormone therapy is not dangerous for everyone, and it's not perfect for everyone. Hormone therapy is like fire. Used well, it warms the house. But if used carelessly, it burns the kitchen down. The key is context. Who, when, what type, what dose, what route, and what goal. Here's what is not controversial. Menopausal hormone therapy is the most effective treatment we have for hot flashes and night sweats. It can also help vaginal dryness, painful sex, and some urinary symptoms. And while you're on it, it helps preserve bone density and reduce fractures. The controversy is about risk. And the reason it's confusing is because people talk about HRT like it's one thing. It's not. There are switches that completely change the conversation. Switch number 1. Systemic versus local. Systemic therapy affects the whole body. That's pills, patches, gels, sprays, and some vaginal rings. This is what we use for hot flashes and night sweats. Local therapy is usually low-dose vaginal estrogen. It's mainly for vaginal and urinary symptoms. Much less whole body exposure. Different risk discussion, different goal. Switch number 2. Uterus or no uterus. If you still have a uterus and take systemic estrogen alone, the uterine lining can grow too much. That raises endometrial cancer risk. So many women with a uterus need progesterone or a progestin as protection. If you've had a hysterectomy, you may be a candidate for estrogen-only therapy. Different risk profile. Switch number 3. Route of estrogen. Oral estrogen goes through the liver first. That matters because it can increase clotting signals and affect triglycerides. Transdermal estrogen patch, gel, spray bypasses that first pass liver effect. For women with clot concerns, many women prefer transdermal when appropriate. Not a magic shield, just smarter risk management. Switch number 4. Timing. This is huge. Starting hormone therapy at 52 is not the same as starting at 72. In general, the benefit-risk balance is often more favorable when a woman is under 60 or within 10 years of menopause onset, and she doesn't have contraindications. Starting later tends to raise absolute risk for stroke, blood clots, and some cardiovascular outcomes. Now, why are so many women scared? Let's talk history. In the early 2000s, the Women's Health Initiative, abbreviated WHI, was a massive study. It changed the narrative overnight. The headlines basically told the world, hormones are dangerous. But here's what many people never heard clearly. WHI tested specific formulations, primarily oral conjugated equine estrogen with and without medroxyprogesterone acetate. And it included many women who were older and often far past menopause. The focus was chronic disease outcomes, not symptom relief. So what happened? A lot of women who were good candidates for symptom treatment got swept into a fear-based message that didn't fit their situation. Fast forward to now. We have decades of follow-up data. We better understand the timing issue. We have different routes and dosing options. And guidance is more nuanced. Important point. Modern experts generally separate two goals. Treating symptoms is one conversation. Preventing chronic disease is a different conversation. In fact, major preventive guidelines say hormone therapy should not be used solely for primary prevention of chronic conditions. Now let's talk about the topic that brings a lot of you here. Breast cancer risk, especially if you have family history. First, I want to say this clearly. If you've had personal breast cancer, systemic hormone therapy is generally not recommended. That becomes a specialized discussion with your oncology team. No social media shortcuts. No one size fits all. But a family history is not the same thing as personal history. Family history means we personalize. It does not automatically mean never. Here's the nuance that gets lost online. Different hormone regimens show different patterns in major research. In WHI follow-up, estrogen-only therapy and combined estrogen-progestin therapy did not behave the same way. And observational studies suggest breast cancer risk can increase with longer duration of many systemic regimens, especially combined therapy. And that risk may vary by duration and the type of progestin used. Translation? This isn't hormones equal cancer. It's which hormones, how long, in whom, and what is the baseline risk. That's real medicine. Now, let's address estrogen dominance. That phrase is popular, but it's not a formal diagnosis in most major medical position statements. A lot of symptoms people blame on estrogen dominance are often better explained by hormone fluctuations in perimenopause, sleep disruption, chronic stress, insulin resistance, alcohol, ultra-processed foods, and inflammatory load. And this is where your keto improvement matters, because improving metabolic health can lower inflammatory noise. Better metabolic health can improve sleep. Better sleep can reduce symptom intensity. And fat loss, especially visceral fat, often helps hormones and symptoms feel less chaotic. Do we have perfect studies proving keto treats menopause? No, but the clinical reality is this. When the root issues improve, sleep, insulin, inflammation, many women feel better. And even if hormones are still needed, a healthier baseline can improve safety. So what should a woman do if she's unsure? Instead of asking, are hormones good or bad, ask better questions. Here are the 5 questions I want you to take to your clinician. Question number 1. What symptoms are we treating? Hot flashes and night sweats, or mainly vaginal dryness, painful sex, recurrent UTIs, urinary urgency? Because if the symptoms are mostly vaginal and urinary, you may not need systemic hormones at all. Local therapy or non-hormonal options might be enough. That's the lowest exposure approach for many women. Question 2. Do I still have a uterus? This immediately changes the plan. If uterus is present, systemic estrogen usually requires endometrial protection. Question 3. What are the major contraindications? This includes unexplained vaginal bleeding, prior blood clots, prior stroke or heart attack, active liver disease, known estrogen-sensitive cancers, or high inherited clot risk. If those are present, we pivot to non-hormonal approaches. Question 4. What route makes the most sense for my risk profile? If clot risk is a concern, ask about transdermal or oral. Again, not because it's risk-free, because route matters. Question 5. If I need progesterone, what kind and why? Progesterone and progestins aren't identical. Side effects differ. Sleep effects can differ. And the risk discussion can differ. This is where experience matters. Now, what if you're thinking, I don't want hormones at all? Good. That's not anti-science. That can be a totally valid choice. And you still deserve options. Evidence-based non-hormonal options for hot flashes include certain SSRIs, SNRIs, gabapentin, and other prescription choices. There are also behavioral approaches like cognitive behavioral therapy for symptom distress and sleep. And there are newer non-hormonal medications that target hot flashes through brain pathways with their own monitoring requirements. The point is, you have options. You're not stuck. Quick note on bioidentical hormones. There are FDA-approved hormones that are chemically identical to what the body makes. Those exist. The bigger concern is compounded custom hormone products marketed as safer or more natural, often without the same quality control, dosing consistency, and long-term safety data. Natural is not a safety label. Poison ivy is natural. So is a bear. Neither belongs on your face. Now, let's put this together in a simple framework. I call this permission plus caution. Permission. You don't need to suffer in silence. Hormone therapy can be life-changing for the right person at the right time for the right reason. Quality sleep matters. Mental health matters. Relationships matter. Work performance matters. Feeling like yourself matters. Caution. We don't use hormones casually. We screen for contraindications. We match the tool to the symptom. We use the lowest effective dose. We choose route thoughtfully. We reassess regularly. That's the grown-up, science-based approach. Not fear, not hype. And let me pause for a second. If this is helping you feel clear, hit like and subscribe. Because this channel is where we take confusing health topics and turn them into usable decisions. Now, let's review. Here's a simple next step checklist you can screenshot. Step 1. Write down your top 2 symptoms: hot flashes or night sweats, sleep disruption, mood changes, vaginal dryness or pain, urinary symptoms. Step 2, confirm uterus status, yes or no. Step 3, review the red flags: history of clot, stroke or heart attack, personal breast cancer history, unexplained bleeding, liver disease. If yes, hormones may not be the right tool. Step 4, decide systemic versus local versus non-hormonal. Systemic for whole body symptoms like hot flashes, local for vaginal urinary symptoms. Non-hormonal if risk profiles say not worth it or preferences say not for me. Step 5, if systemic is considered, ask about route, oral versus transdermal. Step 6, set a follow-up plan. What's the goal? What's the trial period? How do you reassess? Because the goal isn't be on hormones forever. The goal is restore quality of life, lower suffering, reduce risk, and keep the decision patient-centered. And I'll end with this. Menopause is not the end of your vitality. It's a transition. Your body isn't broken. It's giving you feedback. Sometimes the root cause is metabolic stress. Sometimes it's sleep deprivation and cortisol. Sometimes it's inflammatory load. Sometimes it's trauma and overload. And sometimes hormones are the right tool to stabilize the system while you work on the deeper foundations. So to my follower, your caution is valid. Your improvement on keto is encouraging. And your next step is not pick a team. It's pick the right tool for your body and your values. So I want to hear from you. Are you in the no thanks camp, the maybe but nervous camp, or the I tried it and it helped me a lot camp? And if you want more root cause menopause content, metabolic health, insulin resistance, sleep, stress, and nutrition, check the playlist in the description for more videos. Thank you for coming to my video, and I'll see you in the next one.